Good afternoon. I'm going to talk about the cost effectiveness of medical innovations, and more specifically, I'm going to go into detail on a custom printed implant for serious acetabular defects, and specifically for revision surgery. Okay, so we all know that innovations are the drivers of economies and makes us move forward, but we all also know that mostly there is an additional cost that is associated to it. So that begs the question whether that additional value that is generated by the innovation is correlated with an appropriate cost, or if the cost is too high. The same accounts for medical innovations. When we go see what the World Health Organization is saying about health technology assessment, it is that the systematic evaluation of property, effects, and/or impacts of health technology, and it is a multidisciplinary process of evaluating the social, economic, organizational, and ethical issues of health interventions or health technology. The main purpose is of conducting an assessment to inform policy decision-making. So basically, what we do is we make a systematically evaluate technologies in order to make decision-making easier. So I'm going to start with a little bit of basics on how health economics works. So most people shouldn't be, we shouldn't explain that there is more to value and medicine than only the length of life. We should actually also incorporate the other dimension, which is the quality of life. In health economics, we use quality-adjusted life years, or QALYs, to do that. Let me explain that really easily. Like one quality-adjusted life year basically is the value is one QALY would be 1 year of perfect health. So, for example, if we have a utility of 0.5, and we take that for 10 years, we would have a QALY of 5. So if we find some procedure that would gain us 1 QALY over the 10 years and gain actually the utility to 0.6, and we would gain 1 QALY over these 10 years. Another procedure could add 2 years, but at the same level of utility. So there as well, we would have 1 additional QALY. Another technology might actually do both and generate 2.2 QALYs. Okay, so we have the value side and health economics, but we also have a cost side. And that cost side is different depending on the perspective we take. For example, the cost for a patient is not the same as for a hospital or for a doctor, or even for a healthcare provider or an insurance company. So we also always have to take into account the perspective we're looking at. To combine both, we can put cost on the vertical axis and health effects on the horizontal axis, and we can plot on the current care. In this case, it's the middle of the graph. When we have an innovation that is generating less health, we're immediately in the red department, and we will not consider it further. On the other side, we can have an innovation that is adding health, and there, when it costs less, it's obvious that we will take that one, and we will talk about a dominant strategy. But obviously, most innovations will account for a certain cost that will provide the additional health. So there begs the question, what costs can we take for that health that is generated? And historically, the threshold is put on $50K in dollars for 1 QALY. If you have an innovation that is costing less than the 50K, then we would say it's cost effective. If it's more than that 50K, we would say it's not cost effective. The 50K is discussed at the moment, since a couple of health economists are actually saying that the tendency should go up to more like 100K for 1 QALY. So, for example, a cost-effective strategy would be in the green. So now let's go to 3D printing, and we have a working example of the 3D printing acetabular implant. we always compare the new innovation with the current state. And to do that, we start from clinical evidence, and that's basically clinical studies, healthcare insurance data, or governmental data. The data we will be using to generate usable data, which will be used to generate the structure of the model, the transition probabilities, utilities and cost, and obviously we will take into account the complication profile, which will be driving all of these. The model that we have been using to do that is every time we use a model, both for a separate model for the innovation and a separate model for the current state. We've been modeling it on a 10-year time horizon with 20 iterations and with a 6-month time interval. So actually it's a Markov model. It starts with the initial revision surgery using whether the new implant or the current state, and it goes then after 6 months. You can either be in the successful revision, have a successful revision, or need a new revision, a re-revision, or need a new revision, but it is not possible to perform anymore. Obviously, we also have the state where the patient is deceased and where he stays at. To generate, to use the evidence that we found in the literature, we have been compiling the complications profile, because this will be driving the main costs and the utilities for each implant. For the normal standard of care, we have been using four recent publications compiling complications like synovial nerve pain, bursitis, dislocation, loosening, infections. These are all publicly available publications. For the new innovative technology, we had to use what we could find, and that's mostly the problem with innovations. We've been using data from a master thesis, which had the most information that we could find. To generate the utilities and transition probabilities and the cost, we've been basing that on the implant's profile. So for each model, we've been looking at the complications, the revalidation time, the length of stays in the hospital, and things like that. Every utility and transition has specifically been adapted to the age of the patient and the gender of the patient. For the transition possibility, it's also dependent on the current state at which the patient is. And for cost, we've been using the public healthcare provider perspective. So let's give a potential patient. So we have been starting with a patient who is less than 65 years old and a male who needs a revision and has an acetabular apoptotic type 3B defect. So it's a really big defect and it's not easy to treat. We've been using the data for both modeling with the standard of care and the new implant. And as you can see, with the quality is a bit higher in the new implant than for the standard of care. But like expected, the cost is as well a bit higher. The new implant is actually twice as expensive as the current standard of care. So that is the main driver of the cost. Well, for the old, it's more the complications that add a lot of cost. When we're going to look at the difference between quality and cost, and we're going to divide the cost by the quality, we can find what it would cost to generate one extra quality with that new technology. So we will calculate the ICAR, which is the incremental cost effectiveness ratio. In this case, we have one of 17,000 euros, which is way below the threshold that we initially put at 50K. So we've been doing that for all other profiles, so for all the older patients, male, female, and calculating the average. And we could notice that every time we calculated ICAR, when we had younger patients, it would be cost effective, while when we go to older patients, we would be flirting with the limits of cost effectiveness of be way above it. So we've been calculating with certain values, but the values can change. We are prone to mistakes and to differences, to variations in our data. So we are not certain about the results of every study and the compilation of the studies. We can have mistakes in the calculations of the utilities, which are not completely the same as what the actual state would be. And same with costs. They can have a variation between the population. So we had to calculate what is the impact of one of these mistakes, or what is the impact of a change in one of the chosen values. To do that, we have been conducting sensitivity analysis, and we have been doing that by changing the variables with 30% up and 20% off once at a time. So we kept all of them constant and we changed one. And by doing that, we could see that the cost of the implant itself was the main driver. This and the cost of the surgery, these could influence whether the technology would be cost effective or not the most. Followed by the rate of re-revisions and the utility that was used to assess the successful revision. When we also wanted to calculate what would happen if we would change all of the variable at once. To do that, we estimated we put a certain statistical profile on every variable, and we run random numbers specific to that statistical distribution. When we run that, like in the Monte Carlo simulation, over 10,000 iterations, we have that kind of plot you can find here. That plot, we also add the threshold, and where we can find that only 1 out of 10,000 iterations is flirting with the line of the threshold. So this is the case for a less than 65-year-old male subject. If we recap a little bit, we would be situating where the star is situating, so we have a cost-effective strategy. If we do the same with, for example, an 85-year-old woman, we would have a base case of 55,972 euros. So basically, we would be just above that threshold. If we do the sensitivity analysis, then we would see a plot where each case is representing one specific case that is actually in the middle of the threshold. So approximately half of the cases is above and half of the cases is below. So in this case, we are approximately on the threshold, but we know that our average is above. So we would be tempted to say, like, yes, this technology will not be cost effective in that specific case. So if we have to conclude, we can say that this implant is providing good value for money, but only in cases less than 80, where the subject is less than 85 years old, and it would be cost effective at a 50K per quali. Our base case that we took was a 65-year-old man, and there it was highly cost effective. The price of the new reprinted implant and the price of surgery, revision rate, and the utility estimate would be the biggest, would generate the biggest variance if they were about to be changed. So these have to be taken into consider really closely. If we have to take into perspective the new innovations, then we have to say that the biggest difficulty that we find in estimating innovations is that the lack of data that is generated, especially scientific data. So therefore, it would be good to generate way more early data. And voices are up to actually, by some health economics, to actually start reimbursing early on for a limited amount of time, just to generate that evidence so we can check if an innovation is worth the cost. Using these models can be used in two sides. It can be used to prove the value of the innovation, but it can also be used to estimate what price a company can ask for a given innovation. So if we have to take all medical 3D printing into account, then we can say that you have a tendency that complex cases will be cost effective, while the normal standard of care, that the standard procedures that just where they add the 3D printing will not be cost effective. So we have to look out at that we use 3D printing for for procedures that have a high impact on quality of life, like for example in young patients and where the morbidity is really high when it is associated with a failure. Thank you for your attention.